Yeah, well, thank you. It's good to be here, and thank you for asking me to speak to represent our study, which doesn't have data yet. We'll talk about the study design and our approach to exposure assessment. So the objectives are to characterize the impact of deployment-related PM during the time of deployment, and afterwards, when the formal operation ended, on pulmonary health. And our main outcome is FEV1 assessed by spirometry. So assess the association of cumulative exposure to fine particulate matter, PM2.5, during deployments to 7 key countries that account for most of the deployment time. These are land-based deployers: Afghanistan and Kyrgyzstan, Iraq, Kuwait, Qatar, UAE, and Djibouti, with FEV1. The secondary objectives are to look at healthcare provider diagnosed asthma as an outcome and deployment duration, and a number of other secondary outcomes, such as respiratory symptoms. So the approach is to recruit 5,000 veterans at 6 VAs geographically dispersed, who deployed beginning in 10/1/2001 to the current date. With these veterans, we obtained deployment history by interview, which I'll talk about, and we linked that to, we linked that to the PM2.5, and we had another extensive exposure questionnaire. We assess respiratory symptoms and asthma history, other respiratory disease history, and conduct spirometry, pre and post bronchodilator. We're going to create a spatial temporal exposure grid of estimated PM levels during deployment, and I'll tell you how we're going to do that. We're going to link this exposure grid with the individual's location that they give us during their deployment and sum up the PM2.5, and then look at the association between deployment-related PM2.5 exposure and pulmonary function, and assess our secondary outcomes. Our data collection started last year and is scheduled to go through September 2022. So the recruitment is not just VA-based, but we use the Defensive Manpower Data Center database, which is a repository of all deployed, all military personnel, and we update the contact information, and we identify persons in the, not the Navy, but the other services, not Navy or Coast Guard, but the other services. We have an invitation letter to an information form to participate in a 3-hour assessment at the 6 VA medical centers throughout the country with a $250 incentive. We have 3 rounds of mailing, 7 phone messages over 17 weeks. We screen them to make sure that spirometry can be done and represents a usual state of health, such as no recent surgery, lung conditions, no recent respiratory illness. And through the end of August, we have a 28% response rate in terms of who we tested. And if you look at scheduled visits, but yet not coming, at 36%. And we've got about 25% of our cohort tested so far. So the interview consists of a military history overview. We get the dates of their deployments starting in 10/2001 and later in those 7 key countries. We also ask about non-OAF, OAF, OND deployment dates throughout the U.S. and the world after 10/2001. We have an exposure questionnaire. We ask about specific exposures to while deployed, a similar exposure history while not deployed, a civilian exposure module, occupational module, an extensive health, smoking, and demographic questionnaire, getting at respiratory symptoms and respiratory disease, other comorbidities, a medication inventory with a focus on pulmonary medication that they're taking, and then some self-completed modules, a PTSD checklist, anxiety screen, a depression screen, a combat exposure questionnaire, PHQ-15 to review general somatic symptoms, and the VR-12, which is an overall measure of quality of life, global health. So the key to the study, I think, is, in terms of exposure, is a very structured interview where we ascertain your deployment history that is really not yet available in an organized way. And we have a Google Earth map where we've accumulated a list of over 1,200 bases in these 7 key countries with geographic coordinates from a variety of sources. And for each deployment, the veteran is asked sequentially about the date he or she arrived, to the nearest week, since the exact date is probably, it's hard to recall, what time of the month, where he or she was first located, and then sequentially go through the locations until they leave, and the interviewer works with the veteran with a Google Earth map, honing in on the various bases. They have a chance to tell us, no, I wasn't here. You don't have the right coordinates, and we've found a few bases that we didn't pick up that way. And for moving around during deployments, we would take a period of movement the idea is to average the exposure at those coordinates. So we have a stationary, people go from base to base, or there's some people move around a lot. We try to capture all that. We create we've been planning to spend a temporal spatial matrix for each participant to reflect time and locations. And this is just meant to be a conceptual overview to our modeling approach using NASA satellite information and Air Force visibility stations and ground level PM 2.5 stations that we use for calibrating our exposure model. So this is work conducted by Petros Katrakis and his group at the Harvard School of Public Health, where we use Air's optical adapts visibility, dust measures from your satellites, meteorologic variables, land use variables, of course, the dates, with a random forest approach to predicting visibility, the cells with the satellite data available, and then we would fill in, use that model to predict visibility based on Air Force visibility measurements at airports throughout the region, and then using the predicted visibility for all cells. As you recall, visibility is one of the first measures that we use to study air pollution. So how far you can see is proportional to PM 2.5 in the air. And using this visibility map that we've created about on a 1.1 kilometer grid, we will then estimate high resolution PM 2.5 exposures using ground level stations in Kuwait, including at the U.S. Embassy and sites that we're operating out in Kuwait to get at that regional estimate of PM 2.5 using measurements to calibrate these visibility measures. Let's see, go forward here. Oops. So this is a pilot study that we did to demonstrate the feasibility, and this was published in 2017. And we matched PM 2.5 data and average visibility at 3 sites in Kuwait from 2004 to 2005. And these visibility data are available through the U.S. Air Force. And these are included data collected at Kuwait International Airport in Camp Udari in Kuwait. And we calibrated PM 2.5 to visibility plus relative humidity. Validated the model doing a tenfold cross-validation and found a very, very high R squared looking at the relationship between visibility and PM 2.5. So this is estimates of exposure at 104 sites where we had visibility data in those 7 key countries between 2000 and 2012. This is monthly averages, and the predicted PM 2.5 values in micrograms per cubic meter I see are quite high, but within the range that the collected by the DoD and their sampling efforts at about the same time. So I think this is sort of validates the previous sampling that was done by DoD. So once we have the person's exposure history, we link them with a weekly PM 2.5. We're going to do this on the weekly level. And we're going to calculate microgram per cubic meter weeks at each location, sum the PM 2.5 exposure values, and then use this to look at our association between current FEV1 and the secondary outcomes and cumulative PM 2.5. Now, to get at burn pit exposures, on our questionnaire, we try to identify more highly exposed persons, such as work at the burn pit, smoke coming into the living room or work area, and exercise near the burn pit. And this is consistent with the 2011 IOM report that talked about these folks like parts of being more heavily exposed, and to identify epidemiologic efforts on identifying these persons. We are also going to be using NASA satellite fire products. There's imaging available and fire product, the NASA satellite data, to get at locations of burn pits and try to identify burn pit-related PM2.5. So take our locations and use satellite techniques to get at these an active fire signal in the proximity to the base. And then we're going to be using these as self-report and satellite sensing measures as alternative exposure measures. But this is really a secondary analysis, the way the study was designed. Finally, we actually have some ancillary study funded to get at some more clinical and lung disease-based outcomes. So we have 3 VA Merit Review grants recently funded to study a relatively small number of people, but I think to look at some important outcomes where we're going to be taking 320 essentially non-smokers enrolled in SHADE with or without respiratory symptoms for additional assessment. And we're going to be doing inspiratory and expiratory CT scans, low-dose scans, analyzing them quantitatively for percent emphysema, gas trapping, and small airway disease, drawing blood for inflammatory and COPD-related biomarkers, T-cell immune response, lung volume and diffusion capacity in these 320 people, and doing impulse oscillometry and lung clearance index, and looking at their IgE and CBC with differential. The plans being to assess associations with symptoms and deployment PM2.5, and determine if any of these characteristics cluster together and they cluster with cumulative exposure. So that is my last slide, and I can take questions about our study and our ancillary study.
Thank you very much. Questions for Dr. Garshick?
Yes, thanks. And really, impressive effort in terms of the exposure characterization. I had a question about the response that was just confusing. So you had about a 30% response
right,
rate.
So far.
At this point, yes. So that's what I'm getting at so far. So you've already had sort of intense testing of about 1,000 people, but you're actually anticipating a much better response than that, or is that initial response, is that what you're looking at?
Well, I would say that we'll see what we get, but we're really just tapping. The recruitment field the potential population is very, very large. And we're recruiting initially within 25 miles of 6 VA centers around the country. And I think, if you counted what was actually in the pipeline to come in, it was higher than 30%. But in fact, in such a large study like this, that's a very reasonable response rate. And I think, of course, you don't know if symptomatic people come in, or that's always an issue. But I think one of the differences between this study and other VA cooperative studies is using a DMDC to recruit. So we don't have those numbers to tell you quite yet, but we're not recruiting on the basis of VA getting VA care. A lot of these people are not registered ever in the VA. We're recruiting based on a land-based deployment and being in the military during that time period.
So are you going to get, at the end of the day, you think you'll have a denominator?
Oh.
A denominator of potential recruitments versus those that actually...
Oh, yes. Yes.
Yeah. I mean, you're going to be able to have sort of what the actual percentage...
Oh, yes, of course. We think it hasn't changed much since we started over the first, over 1 year. It's been pretty steady. Yeah, no, I think it's going to be if I had to predict about that. And then we can expand, the plans are to expand to 50 miles within these VA sites as well if we need to.
Will you have some demographics on the non-responders that you'll be able to compare to your responders?
We will, because we have that from DMDC. We know their age, we know their gender, we know their military branch, we know how long they served. So we'll have a lot of information. Their military rank, for example.
Will there be, or has there been any validation of deployment in terms of where, when, and how long? Because it was self-reported, correct?
It's self-reported. So There is information available in DMC on deployment that's somewhat limited, and it happened a little later during the, tracking that happened a little later during the deployment period, where people would swipe their card when they showed up at a mess hall or deployment area, and how frequently that was done is somewhat suspect. So we know the country, and we know the dates they arrived. When the veteran comes in, we have a little sheet of, yes, you're in this country for these dates. We don't know where they were in that country during those dates, but we can compare at least country-based and the general date of when they arrived and left theater. So in terms of validating, this is, I think, is the best there is. Now, in terms of just anecdotal experience, people seem to remember where they were and can hone in on small fire bases on mountainsides saying, I was here. So at least anecdotally, people seem to have no trouble remembering. Most people can remember where they were.
In the sub-study, the merit study, where you're looking at the control group who no smoking and no symptoms, are you matching them at all in terms of exposures or duration of deployment with the group with symptoms and smoking?
Well, matching, that's a hard thing to do in terms of study design. And I think that we weren't going to do that, but study differences in deployment and symptoms. I mean, we're pulling from the same pool, so it's really going to be matching on the, on symptoms, since that's what brings people, symptoms and no smoking, since symptoms bring people into clinical evaluation. That's why we chose that.
But obviously, if they haven't had a similar type of exposure, it becomes a much tougher correlation or match.
It does. And we debated this in terms of the ease of design and getting people into study. I think we'll start and see what we get, but this was the initial effort to keep it simple.
Could you say a word about the training of the personnel at the 6 sites, just in terms of, and the equipment being used? Is it uniform? Have you done anything cross-referencing?
So we're using the NDD spirometer that doesn't require, we check the calibration, it doesn't require daily calibration if you check it per ATS standards. So that's all uniform equipment. And then we have a period of training of the person doing the spirometry with certification by Bob Jensen, who is expert in running large study-based training methods. So the technicians get certified, and then every month it's reviewed. The data is reviewed at the technician level to see if there's anybody having some outlier, not doing good spirometry, and that person gets feedback. So we review both at the technician level and the center-based level to try to ensure quality. And then we have refresher training, at least on a yearly basis. We just had our yearly study meetings to refresh it, to go over problems. So that's our approach to quality assurance.
Just a quick question on the PM time series of the predicted PM. It looked like they were all sort of summertime peaks. So does that imply that it's mostly dust, sand that's contributing to the big peaks of PM?
I'd have to go back and look at that, but I think there is, if my recollection is that other work we've done is the relationship between, dust storm times and higher PMs. There is a variability by season, and it seemed to go up actually over a calendar year if you look at that, with the idea that the region is getting more arid over time. But I think the PM is very likely a mixture of dust storms, local exposures, industry, burn pits, military. It's a whole mix that depends on the meteorologic conditions at the time.
Thank you.